I think that you all probably could give this talk better than me, and I was a bit apprehensive when I was asked to give this talk because I'm sure that you know more about shared decision making and what would make the process much more efficient and helpful for patients if you were in charge of it. But I'll talk to you about my take, and then we can perhaps have some sort of dialogue about where you think we can make this more efficient. So, shared decision making has a lot of buzzwords: mutual, consensus, deliberation, information exchange. There is no singular in there. There is no one way. There is no paternalistic. It's all an open dialogue, exchanging information between doctor and patient and establishing that good connection. And I think that needs to happen from the very first consultation and very first encounter that you have. Whether you've had that with your doctor, you may have, but I think that's what everyone should strive for. And it is difficult because specifically in valve disease, we're dealing with patients who are over 65. Many of them still have that very paternalistic view where you're the doctor, you tell me what I need, I'll listen. And it's very hard to stay away from that, because when I do challenge it and I say, well, actually, you can make a decision, you can help me make the best decision for you, they often would say, whatever you think is best. You know everything better, you know the information, so whatever you decide. Then I always get the question, what would you do if it was your father? What would you do if it was your mother? Which is the clever one. That's the clever question. And it's never different, really. Perhaps my mother or father would have the benefit that I would probably attend with them, so I would be able to explain things better. But I hope that your physician would be able to explain things in a way that is digestible and that is something that you can take away, think about, and then come back with questions. Since the 1980s, though, this paternalistic model has been wiped out completely, and now patients really want more rights, they want more ownership, and we love that. We love them knowing more about their condition. And that's what we need to work towards, maintaining that level of education and using it to our advantage. The different models of shared decision-making, as I had mentioned before, paternalistics, where physicians make the decisions and then the patient take the treatment. There's no patient involvement really. And then there's the informed model, where physicians provide the information, here's all the data, what would you like? And then the patient tells you. And then there's the shared decision-making, where there's information exchange, there's time to go and look up things, the patient asks the relevant questions, and that's really important because patients don't really know what questions to ask. Often when I say, your valve is narrowed, your heart valve is narrowed, there's lots of reactions. Oh no, what do I need? Is it something I'm eating? What tablets can I take? And so,
what does it mean?
What does it mean? Exactly. And how long will I live? So many questions. And I think it's important that the patient gets told the basic information and then understands what to ask. So, why is my valve not functioning? Is there a reason? Is there a complication of this not working? How will that manifest in my day-to-day life? Those things that I think are important, but perhaps they don't know how to ask it in a way that they think is obvious to us. So in the shared decision-making model, information, as I said, should be flowing both ways, but there should be time. And lots of these workshops that have looked at shared decision-making have highlighted that the time is the main constraint in being able to formulate a good shared decision-making encounter. And patients want actual information. So I'm sure you've all been told there's a 1 in 1,000 chance that you'll have a stroke, heart attack, big bleed. It's very general. And it's hard for us to be so specific, but if we narrow it down to the patient-specific reasons, we can say, well, you're at low risk of a stroke, there is some risk, it is very minimal, and this is what it is. Bleeding risk is still there, but you don't have that bleeding risk because you have X, Y, and Z. Or you may have a higher bleeding risk because you're already taking something to thin your blood. So I think those risks need to be tailored too, so that patients aren't all given a blanket figure. And then there's the deliberation phase where patients talk, what if I waited, doctor, what would happen? And I think that's important. Being the devil's advocate, having someone say, well, I don't want anything. What are my options? What are my chances? How will I feel? So those kind of things are important. And we don't now, gone are the days where the doctors say, well, you'll die, you must have this and otherwise it's nothing. It's in today's culture and in today's healthcare, we're all very clear with what the complications are. We're all very clear with symptoms, and we know a lot more. And that's how we can use all of the information that we have to equip us so that we can have the right patient encounter to make decisions. But this decision stage shouldn't happen in the first encounter. It should happen after there's been multiple encounters with both parties, where there's been an opportunity to speak to patient relatives or carers, people who may have questions, and then altogether coming up with a decision. And again, time is the constraint. And so that is where we need to work on. There have been many models for shared decision-making in clinical practice, but usually most of the pathways have suggested to talk first openly about what the problem is, and then talk about the options, and then have a period where patient goes away, looks up things, asks about certain things, and comes back with more questions, rather than having to come back and give an answer or give a decision. And then there's the preferences. This is what I prefer. What do you think? Do you think it would be successful? What are the complications? What is the recovery like? All of those things. And the problem that my colleague mentioned before is that we should be doing this in a heart team. I often get asked, I'm going to have surgery, what are my chances? I can only give them a blanket answer because I don't perform the procedures. But if I was sitting with the surgeon would be able to tailor that answer specifically when they've seen the patient, understand what their medical history is, seen all the imaging, and then they can formulate that answer. So in heart valve disease, many people have given options and suggestions for how we could implement shared decision-making within this space. And it's all about the physician and the patient having more of an active role. Decision aids are so important. So patients knowing what to ask. For example, if I had a mechanical valve, what would my problems be? If I had a biological valve, what's the difference? But that needs to happen, and as I mentioned, it needs to be widely used. The problem is that there may be some pockets of areas in the world that use shared decision-making very well, and some that may not. And so it needs to be uniform so that when we implement guidelines and when we talk to patients, everyone knows what to expect when they're being given information about their condition, in specifically heart valve disease, and then how to make a decision about what to do. So shared decision-making has appeared in the NICE guidelines, it's appeared in the American Heart Association guidelines. But what's apparent is that at the end of those guidelines, where they offer suggestions for improvement, there's always a paragraph on there needs to be more shared decision-making. This is where there's a gap in the market, this is where we need more work, and that's what needs to happen. And so we all recognise that this is still something that we need to work on and perfect. The NICE guidelines are quite good where they have some decision aids for patients, but they have it for specific things. So if you've had a chance to look at it, you may know, but they have a decision aid, for example, for someone with breast cancer, So they have it's a formal kind of document where patients can look at it, and they have some prompts so they know what to ask the doctor. And then there's a physician section and there's a patient section. The physician has to break down the complications of surgery in a way that the patient understands, and the patient is advised to ask specific questions that are going to give them the information that they want. So it's really helpful, and I think having decision aids like this for specific conditions are really helpful. There's also a decision aid for people undergoing treatment for infertility. There's a decision aid about people undergoing prostate cancer treatment. So in the NICE guidelines, this is the UK guidelines, there are specific decision aids for that, and that helps patients to kind of focus their mind on what they think they should ask. Especially in that phase where you're being told by the doctor something's wrong, you automatically blank out. You don't know what to ask, and then when you finish or when you leave, you're angry that you didn't ask the right questions. You're going to go back to your relatives, they're going to ask you what happened, and you're not going to be able to say anything. So these prompts are helpful because then it will help the dialogue, and then you can take it from there. But the barriers of this, as I mentioned, and I keep mentioning, time constraints. The time constraints. However, if we're all taught to do it properly, we can really perfect how long it takes us to do it. If it becomes, as you mentioned, the stethoscope check, if it becomes common knowledge, if it happens without even thinking regularly, you become better at it. Practice makes perfect. So if we can do shared decision making in every encounter, we'll all become a lot better, and the time constraints will be halved. The lack of applicability due to patient characteristics in clinical situations. Sometimes in an emergency setting, obviously we can't do shared decision making, but often those are the times where we may need to. We should have, before even thinking about intervening in an emergency setting. Is this really going to make a difference? So everything needs to be tailored to the patient. There are not many resources out there. If you ask many physicians, they think that shared decision making is just speaking to the patient, telling them their options, and then waiting for an answer. But it isn't that. It's much more than that. And as we evolve and as healthcare evolves, it's going to become more intricate. And then there's insufficient training. No one knows how to do it. I personally have never had training on shared decision making. I've adapted my way from watching how things are done and seeing things, seeing complaints, hearing issues with general communication. But if their training was started from medical school, for example, then it would be open to everyone. So we really need to use this, and we need to propel it forward. We need to make it important so that it becomes a part of the curriculum, becomes part of our general day-to-day practice. The Winton Centre for Risk and Evidence Communication is a centre based at the Cambridge University in the UK, and they've really tried to highlight these problems, and they've published a few courses for physicians to teach them how to use shared decision making in their daily patient encounters. And so they have a primary care version, they have an obstetrics and gynecology version, they have a peri-operative version, so before someone has an operation, they have ways where you can speak to the patient and implement shared decision making.
No one signed up?
Sorry?
No one signed up?
Oh, well, no, I don't think they knew about it. It's when I started doing my research that I found it. So it's really, there are researchers there. There is information out there, but it's about accessing it and knowing about it. And I only just found out about this when I was researching this talk. So I think it's really important that we increase the awareness of shared decision making. And with patient organisations like yourselves, if you bring this to the forefront of your work, that will allow us to then make it even more important and relevant. As I mentioned, there is training for physicians, but there's also training for the patient. What to ask, what kind of questions are relevant for this particular condition. And then no question is too silly. There are often patients who are worried about asking a silly question. And I think that needs to go, because any question is valid, because it's about you and your life. And If you don't ask it at the time you need to, you'll regret it. So I think it's important that you know what to ask. You ask everything that you think you should. And also the physicians need training on how to respond, how to give information in bite-sized chunks, not all in one go. Check that they've understood. I draw all the time. So I draw things, and some people prefer a visual aid. So it just depends on what people prefer. And this is something that we can implement. There's been an article with the BMJ about making good decisions in collaboration, and it starts to introduce shared decision making in practice. But they mentioned that there were 4 GP practices in the north of England that wanted to incorporate shared decision making, and they introduced a workshop and a focus group where they took 4 GP practices and their staff, and they trained them for a number of weeks on shared decision making using specific tools, decision aids. They did workshops, they did group work, they had role play sessions, and then they had feedback, and then they practiced it over and over again. And that whole thing allowed them to then become more efficient with the process. And that's what we need. But that takes time. That takes time to do. It takes an organisation. It takes staff out of their daily work. But if we can say it's important enough, then it is important to implement. Our patient representative with the British Heart Valve Society very kindly sent me a lot of her thoughts on this topic, because I wanted it to be from a patient perspective. And I'll read it out to you. Perhaps some of you may be able to relate. It would seem that the ideology of shared decision-making is sound in principle, but far from being embedded into the infrastructure of the NHS, which is the National Health Service in our country, in a way that supports both patients and clinicians. Shared decision-making implies that the patient is engaged, informed, confident, and ready to talk. But in reality, many patients are confused, distracted, over-anxious, and ready to run. Patient and carer representatives feel strongly that people, especially those with multiple illnesses, should be at the centre of a closed circle of consistent, smoothly functioning care and shared professional recommendations, rather than from pillar to post. And I find that that's very common. Patients are being seen by different people each time. They can't keep track of their appointments because they're seeing a surgeon, then they're seeing the imaging cardiologist, then they're seeing the someone for a scan. So, they don't really know what's going on and how it all ties together. Health literacy must work and probably be co-produced at the lowest level of comprehension. It must penetrate the blanking out caused by white coat syndrome and counteract the seemingly contradictory nature of some medical discussions. Mutual understanding is essential when it comes to personal preferences, such as timing of intervention, surgical options, choice of device, even the choice to do nothing. For the patient, there's so much to take in, process, and remember. Readability techniques, chunk and check, teach back may help, but reading is only part of the problem. So I can offer you leaflets and say, look, here you go, you can read about this. Off you go. That's all the information that you need. That's not helpful, because you don't know if that's going to relate to you, or if that's even something that you should be doing, reading up on things. You want to be told face-to-face by the doctor. And we're very privileged that the Global Heart Hub and yourselves have made this roadmap. And I think this will be the future for heart valve disease, because this is what we need. We need a stamp, we need a protocol, we need a checklist, and we need some guidance, just like all of our guidelines, on how to make this better for all patients. And there needs to be a common understanding that shared decision-making is the only option, and this is what we're going to do. Every patient encounter should work on that. This should be done from patients, physicians, at local level, and also at every level, from community to specialist care, and even post-operatively. It's really important, because once you've had the operation, you're left on your own. That's it. How long will it take to recover? When can I go back to playing golf? When can I drive? When can I go on holiday? All of these things are important, and often it's just a kind of quick wave and then you figure it out on your own, or you go back and ask someone. So there needs to be a lot more implementation of shared decision making, but also specifically to heart valve disease. We know that there is more out there on other conditions, but heart valve disease is something that requires a lot more understanding. It's something that is a diagnosis that progresses over time, so it needs to be understood for that entire progression. And we need to invest in research where we really do think about and using the people who've been diagnosed with heart valve disease to try and focus our work and make shared decision making possible within this space. So to conclude, shared decision making is a crucial element when managing the patient with heart valve disease. Physicians ourselves need to be trained first because we need to be able to understand how to do this better and streamline the process. Guidelines have acknowledged that we need to do this. So we need to do this and we need to do it properly. It needs to start now. We need to implement a roadmap so it would guide people on what to do. Therefore, we don't need to start from scratch and we all do it in different ways. If we all work from the same hymn sheet, then it would be much better and we all know what we're doing. Patients are facing multiple challenges with overstretched services and they've lost faith in, forget just the National Health Service, in all of healthcare. And so we need to be able to consistently deliver this standard of care. Here are my references if anyone wants to look them up, and thank you for your attention.